Okay, welcome everybody. We'll just wait for a few people to come in. Cool. I see we've got Jess Hennessy, I can see Carol Schober, I think it is, and then Becky Eagling. Hi, Bex. Give that a little bit of time to update. Yeah, it seems like everyone's coming in. So we'll make a start. Thank you for joining us tonight. Hey, Steph. Hello again. Yeah, so this is the second webinar for me tonight. I did one on clinical reasoning back at 6 o'clock this evening. So if you want to join us on the next installment of that, then that's on Wednesday at 6. So we've got part 2. We're looking at ankle and foot clinical reasoning. So looking at a case study. But this evening, and this is going to be something that we'll do weekly. So Dan Lawrence is here. Dan's a physio, written a book, and he also lectures with me with the RockTape team and heads up RockTape UK. So great to have Dan here. I'm going to hand over to Dan. He's going to take you through our first tendon talk. You need to listen up because we've got some questions for you to answer over the next week. So I'll hand you over to Dan.
All right. So yeah, let me just start. So thank you, Mike, for the introduction. I'm just going to have to take my headphones off because I'm just hearing my own voice. We're going to have a look today at a presentation that I delivered in Birmingham last year, and hopefully we'll be back again in November, where we looked at the core concepts. We looked at some evidence updates and some clinical experiences, really to help people tackle tendons, lower limb tendinopathy problems using the best available evidence and really knowledge that's out there at this time, and attempting to condense it into a short space of time, which we'll look to do again this evening. And I've invited Mike to join me so that he could act as a kind of compere and questioner, really, to ask questions, as well as people being able to ask questions on the comments that I can see on the screen here. So despite the technology hiccup, hopefully that plan will work. I've got lots of yeses in the comments, so I think things are going all right at the moment. So this is me. For those of you that don't know me, I can see lots of names I recognize there, so I assume most people do. But there's lots of free education information that I'm putting out there at the moment, including a lot of it goes through the Physio channel, where most of the content is hosted on YouTube. So please do have a look at the Physio channel on YouTube if you have not already. So let's get started. The core concepts. We'll talk about these things today. We'll see how we get on, and we'll come back again at a later time and discuss them further if we need to. So really it begins with a correct diagnosis, and this is really quite simple. It's, are we dealing with a tendinopathy or are we dealing with a rupture? The most common rupture, of course, is the Achilles rupture, but I've also seen ruptures of the upper hamstring tendon as well. I've heard of ruptures of the patellar tendon, but never seen one. And yeah, these are the most common ruptures. Now, if we take the Achilles tendon, in between a tendinopathy and a rupture, there is such a thing as a partial rupture, which often gets treated and managed in much the same way as a tendinopathy. But a complete rupture is a very different beast altogether. And the correct diagnosis is important. And there's a bit of a time sensitivity to it too. So I've seen a few times patients who have had a full rupture. One chap had a rupture about 8 months before, and his rupture had not healed properly. So he was really quite limited by that. And then I saw another lady who'd had a misdiagnosis, and she had a very definite rupture, but unfortunately the first person she saw before coming to see me hadn't managed to diagnose the rupture, and she was on that borderline time frame of not being able to have that conservatively managed. And I haven't had a chance, for obvious reasons, to follow up with her at the moment, but I think she was going in for surgery for the rupture in that instance. When you see a rupture, it is quite obvious. The onset of sudden pain does indicate a risk of a rupture, but that could also be a partial rupture. I had a patient recently who had a partial rupture of, we had him ultrasounded, it was 60%. And it was really quite a significant injury for him, and it took quite a few months to get him back to walking normally again, but we did get there. It just took a long time. So I think that's probably the difference between a tendinopathy and a partial rupture is the length of time that it's going to take to rehabilitate. As for a full rupture, that's usually much more obvious, and it's a very different thing. When we're dealing with tendinopathies, what we usually have is a gradual onset. There's no sudden onset, it's a gradual onset, and this is more indicative of a tendinopathy. Then what we want to find out for patients is, why is it there? Most typically, there's a change in their loading levels, and this often takes a little bit of questioning to get to the bottom of. It's not always apparent when they first start describing what they've been doing. I suppose the one that I see the most often in clinic is the description where the patient will report that they've been running, but that's normal for them. They've usually been running. But when you dig a little deeper, they've usually had a layoff period. They haven't run much for a few months, and they're getting back into it again. So it's this where they go from doing a high amount of loading to a low amount of loading, and then they jump straight back into that high amount of loading. And even that rest break of, say, a couple of months, if they've been quite sedentary during that time, is often enough of a trigger to disrupt the equilibrium and trigger some tendon irritations. Because tendons are slow to adapt. They have a lower metabolism than contractile tissue, and it's often said that tendons have a poor blood supply, but I think that's a bit of a bad description. They do have a low blood supply, but that's normal. That's just the way they are. It's not a problem. It's just the way they are. They're non-contractiles. They don't really need a high blood supply, but they are slower to adapt for that reason. The other thing to think about with tendons, and this is different for different areas, is compression mechanisms. So it's not just the loading and the bouncing and the stress going through the tendon, it's the compression on the tendon. That could be, well, most typically it's compression from the attachment point, the enthesis, the bony parts pressing into the tendon. But for the upper hamstring tendinopathy, for example, it's sitting on your ischial tuberosities, and that's pushing down on the tendon. I'm not saying that's the cause, but that's often something which can cause irritation once there's a tendon sensitivity at play.
Right. We've had a sorry, Dan. We've had a question from Marcus, and I think also with lockdown now as well, where a lot of people are they're exercising more than they usually would. So this is probably a perfect time for tendinopathies to occur. This is, I guess, from Marcus, a question about how you would diagnose it in clinic and what it would look like if it was a complete rupture. Do you think it would be obvious to do that online as well? So if we're the way we are now, would we be able to do some assessments that would indicate it's more likely to be a rupture rather than a tendinopathy?
Okay, great question. Thank you, Marcus, and thanks for picking that up. Mike, so this is what you would do. You would identify that there had been a sudden pain, sudden onset, and they may describe like that kind of a gunshot noise or feeling or something quite profound. That's the first thing. That's the subjective thing. Objectively, they're going to have trouble walking, and there's that test, the squeeze test or the Thompson's test. Basically, when they are on their front and they're relaxed, if they squeeze their calf muscle, it won't move the tendon because the tendon's effectively detached. So therefore, it won't move their foot. So how would you do this at a remote assessment? They would need to lie on the bed with their feet off the end of the bed on their front, and you would ask their partner to look at their feet and see, firstly, if the injured side was dropping down more or was more with flatter, relatively more dorsiflexed. And then you would get them to squeeze the calf muscle on both sides. And if the foot moved on one side but did not move on the injured side, that would be your positive test. And if you were doing that online, you could hopefully see that on the screen, and you could hopefully capture that in video as well. And as long as they had a partner there to, to be your kind of a surrogate assessor, then that should be quite a straightforward thing to pick up.
Brilliant, thank you.
And that would do it. Yeah. Brilliant. Okay, so any questions on what we've looked at on this page here? Nope.
All good. Yeah,
right,
sometimes they take a little bit of time to filter through. So
that's right.
With the just go over the compression mechanisms again. Then for the Achilles, what kind of position would they normally get in that would compress the enthesis of the Achilles, and then for the hamstring again, just going over those.
Yeah, absolutely, Mike. I think I've got some slides on those. Marcus just mentioned something as well. There will be, Marcus is quite right, will there be a lump at the musculotendinous junction? Yes, there may well be. There's likely to be a lack of definition. So where the tendon once was, there'll be a lack of definition when you feel and palpate through the tendon, because you would have lost that tensile structure. It would have come off. So there'll be a definite palpatory feel to it as well.
Yeah, good.
Okay, so if we look at the compression postures, there's different things. So if we look at the Achilles compression postures, if you've got an insertional type of tendon irritation, then it's dorsiflexion movements which will potentially cause the irritation. So therefore, these type of patients often respond well to having shoes with a slight heel on them, or more of a heel to toe drop, as this reduces the amount of dorsiflexion they need when they're walking. So dorsiflexion is the compression culprit for insertional tendon problems. It's less so for a mid-tendon, mid-substance irritation, but those, even then, they can sometimes respond to a bit of a heel lift just for symptomatic relief. For the patellar tendon, there isn't a compression mechanism for irritation for the patellar tendinopathy. Then if we look at the hamstring tendinopathy, there's two classic ones. In the image here on the screen, you can see the guy bending over doing a straight leg deadlift. That's a classic mechanism. Yeah, thank you. Oh, that's good. That's very good. That's a classic mechanism, is that excessive hip flexion. It's not just about the hip flexion, it's about the how repetitive that hip flexion is and how controlled that is as well. So if somebody's used to going into hip flexion and they do that for a few sets to failure, then that's absolutely fine as a training mechanism. But if somebody spends a lot of their time bent over like that because they're a cleaner, for example, then that's the kind of thing that can lead to that low-level overload with a lack of recovery, which can cause that tendinopathy to come on. Or if somebody decides that they're going to get a super toned bum and hits the gym and just does loads of straight leg deadlifts and they're not used to it and they don't allow enough time for adaptation, again, that's another culprit. The less active culprit is the sitting. So simply sitting too much, or particularly sitting on hard chairs where the tendon is compressed over the ischial tuberosities. If you're looking at hamstring tendinopathy, it's that sitting pain, bum pain on sitting, which is one of the key factors, one of the key symptoms for it as well. The gluteal tendinopathy. So in the picture in the bottom right of your screen, where there's a star, I'm going to have a go.
Oh, sorry,
doing that thing there, Mike.
I stole your
thunder. There's a star there. Okay, not as good as you. Where there's a star there, that is the gluteal tendinopathy. Now, the gluteal tendinopathy is actually the most common lower limb tendinopathy. If you work with younger and an active population, you'll probably find for you it's the Achilles. But for the general population, the gluteal tendinopathy is one of the most common. More common in females, the ratio of 4:1, common over the age of 40, but I see it a lot as well in elderly patients who think that they've got osteoarthritis and are actually quite pleased to know they've actually got gluteal tendinopathy or greater trochanteric pain syndrome. It often goes by. Anyway, the way that person's standing, if you stand habitually in that passive resting position, you push out and bow the lateral structures of the hip, and the ITB can therefore push down and cause some compression and cause irritation of the gluteus medius and minimus tendon. So that can be a real factor for irritation, as can any other adduction type movement, like sitting with the legs crossed, sitting in low chairs sometimes as well can trigger it. So that's another classic compression mechanism for those lower limb ones.
Yeah, often get that.
Marcus mentioned about hamstring tendinopathy and sciatica. That's a good question. So hamstring tendinopathy commonly refers down the back of the thigh a little way, but not as far down and as diffuse as the sciatica would. Sometimes, because the sciatic nerve runs close to the hamstring origin, there is a possibility that you can get some adhesions and tethering of the nerve to the hamstring tendinopathy, but usually only in very chronic conditions. And I haven't actually seen this in clinic, but it is something that's been documented as a potential factor in the research a few times. For the gluteal tendinopathy, a bit like sciatica again, it can run down the side of the leg like a sciatic symptoms can, but it just goes down the lateral side of the leg and it doesn't go any further, and it doesn't have those dysthesias, those paresthesia or anesthesia type nerve symptoms that you would get with nerve pathologies. So that's the compression mechanisms just there on the screen. And yeah, we'll move on. I'm just keeping an eye on the comments coming through there. Is this working all right over the microphone and the phone? Seems to be. Yeah. Core concept. Hang on. Pain. Oh, yes, pain. Pain is what has brought the patients to us most of the time. Occasionally a patient will come because they want to improve their performance, or their joint's not moving as well as it should, or they feel an area is not as strong as it should be, or they want to have their gait assessed. But most of the time, for most of us, pain is what brings the patient to us. But it's getting the patient to understand the pain, which is a real key thing. It's there for a reason, but what it means is often not that clear. If a tendon is painful, then clearly there is an issue at hand, and it's not imaginary. And of course, in trying to communicate pain science to the patient, we want to be really careful that we don't suggest to them that we're just saying it's all in their head. So pain is an indication that something should change. And absolutely, you know, we can look at load, we can look at compression factors, we can look at lifestyle factors as well. Generally, though, the research indicates that pain is not an indication of poor structure. And there's a bit of a paradox here, because if a tendon is freshly irritated and very sore, that's actually a good thing. If a tendon's been painful for some time but is somewhat settled and is a bit grumbly and is now much less painful, that's actually a bad thing. The reason is a fresher, more acute tendinopathy tends to be more painful, but its structure is usually sound. An older, more grumbly chronic tendinopathy tends to be less painful, but its structure is more likely to be changed and poor. And that's why there's an increased rupture risk with chronic tendinopathies, because there's less pain, but the structure is worse. In the more acute ones, the pain is helpful because it's protective. The tendon is fine structurally, but there's an increase in pain, and that means the individual's less likely to load the tendon, and therefore it's giving it more protection than perhaps it needs. So there's a pain structure paradox there in terms of what patients are feeling. Similarly, a lack of pain is not an indication of a good structure. A patient's going to be really pleased if you treat them with massage or with tape or with a shockwave, for example. But the fact that the pain has dampened down is not indicative that there's been structural change. The best way to bring about structural change is to change the loading situation for the individual. We'll talk a bit more about that in a moment. This means in practice, we need to keep loading with our rehabilitation even after the pain is reduced. So if after a couple of weeks of isometrics, the patient thinks, great, doesn't hurt anymore, fantastic, Mike's an excellent therapist, thank you very much. Actually, if they just stop the loading and return back to their normal plan, it's likely that the issue will come back again. So structural changes, as a general rule, take about 3 months. So if somebody's serious about getting on top of the tendon pain, they need to stick with a plan, i.e. a progressive plan that's carefully monitored, but for 3 months.
Cool.
Thank you, Marcus.
Just on that, Dan.
Core concept. Okay, education.
Dan, just on the...
I once heard a very...
Sorry, Dan. Dan, are you there?
Sorry, Mike.
Sorry, Dan. Yeah, David. So just on the pain science part that you had on that last slide, what you mentioned not about bamboozling them and overloading them with pain science, but what kind of things would be your key messages in that first session with them? Because obviously you don't want it to come across like it's all in their head, but what would be your go-tos for that first session?
Yeah, okay, good question. So my go-tos would be that the tendon is sensitized, it's been overused, it's still structurally sound, it's still 100% strong, but it's been sensitized because it's been overused too much and it needs some time to settle down and calm down. When it comes to loading, we need to persuade the patient that loading is a good idea. And this can be challenging if you're trying to get them to load a tendon which is hurting. It can go against the grain and seem illogical to them. So what I explain is that the loading is going to help to desensitize the tendon. What I explain is that when they run and hop about, the ankle joint can take up to 13 times body weight, the tendon perhaps less, about 9 times body weight. When somebody's standing on one leg statically, they're simply taking 1 times body weight very carefully through the tendon. So the amount of load going through is far inferior to the amount that would go through even if they were just walking. So by explaining in biomechanical terms that loading the tendon like standing on one leg is very, very minimal and easy for the tendon compared to just simply walking into your clinic, you can lessen the threat for them, and also then just start to educate them about the plan of putting some load through the tendon and reducing the ballistic load, the bouncing rapid type loading as well. So getting the patient on board is really key, and this can take time, and this is where this comes in. This is where education is really important, but I believe this takes time. We can't say, right, we'll have an hour and a half with our patients and tell them everything they need to know, and then that's it, job done. I did hear an excellent physio say that once, and somebody like myself would listen for an hour and a half to tendon talk, no problem, but to a patient, you can often lose them within the first few minutes. So I believe that the patient education probably takes, on average, about 3 sessions. It really does depend, but I don't aim to teach patients everything they're going to need to manage the condition in 1 session. I spread it out over 3 sessions so that I'm not throwing too much information at them in the first session. In the first session, I do want to give them an exercise to do, at least one, but I need to make sure that exercise is not just a stick man or an image or a video. It needs to have meaning. It needs to have justification. Why am I getting them standing on one leg? Why am I getting them doing this long lever bridge, for example? Why am I getting them doing this isometric hip abduction? And the exercises need to have reason. So the patient needs to not just have an exercise, which is often a very simple exercise, but they need to have meaning, justification, and reason, and then more reasons as well as to why they're doing that exercise. When they get home to their partners, I don't want them to say, oh, I've got to lie down and do this and push this way and hold it for this long. I want them to say, I'm doing this exercise because this is going to, and this is the reason why I'm doing this particular exercise. That's what's going to build the buy-in and the rapport, patient alliance, and that's what's going to build the strength of the adherence to the exercise as well. Tendon exercises are easy, guys. They're really, straightforward. You choose a small selection of there's a small selection of exercises. You can choose one for each lower limb tendinopathy. There's research saying this exercise or that exercise. They're really easy to do. The fact is just getting patients to do them. And if you've ever had a tendon problem yourself, you'll know that just getting them done is often the biggest challenge. So therefore, we want to also instill some positive outcome expectation. We can talk to them about our previous patient successes. We can talk to them about the research. We can tell them why they're doing that exercise. And I often believe that the success of an exercise is determined before we even set the exercise. Some of the things we haven't talked about probably enough are patients having some barriers to doing the exercises that we're setting them, patients having some barriers to loading. If they're unsure about putting load through their sore tendon, if they're unsure when they leave your clinic, it doesn't matter if you've given them the world's best exercise. If they're not sure about it, then that exercise is not going to work for them. They're going to even not do it or give it a half-hearted approach. So it's really getting the patients set and clearing barriers and getting them on the right road before you even think about setting one exercise. We also need to think about realistic expectation. You may have magic hands, but tendon problems aren't going to disappear in a few days. They're going to take a number of weeks and potentially months, and they are going to suffer pain flare-ups as well. These are things that need to be monitored and managed accordingly, and the pain is somewhat acceptable as long as they're working with it in the right way. So to do some loading exercises in the presence of pain is acceptable in the first instance, but to just ignore the pain and feel that they can run through it is not a helpful way to go about doing things. So there we go, moving on. Okay. In most of my presentations, I present a slide similar to this. It's really comes down to load at the center of how we manage tendinopathy. Because it's an overuse or wrong use type of issue, we need to adjust the training load and increase their load tolerance. Mm-hmm. So for example, if somebody comes in and they've been running more than usual, we might see some of that at the moment, or hear about some of that at the moment and see it when we get back to practice. But their training load has increased and their load tolerance has not, because they haven't had enough time to adapt. Mm-hmm. So it's very sensible to reduce their training. We might suggest that they cut their training down by 50% just to allow a bit of a window of recovery for them. But if that's all we do, then we don't actually improve their load tolerance. So we're not helping them to get past that load barrier. Similarly, if somebody comes in and they're training a lot and we say, oh yes, brilliant, I know some great exercises that I read in a book and I'll get you to do those. If that's all we do and we don't allow any capacity for recovery by reducing their training load, then we can't increase their load tolerance because there's just not enough time for them to repair and to recover. When we adjust their training load as well, we need to get smart with that. We need to get smart by looking at what the most aggravating types of training are. Maybe they're doing some hill sprints. Maybe they're doing some faster paced runs. Maybe they've started some plyometrics. Maybe they've got some other stresses in their life which are not to be overlooked or underestimated. So they have not got enough time for recovery, or they're working night shifts, a whole bunch of different things that can affect their training other than just their training. So looking at those two factors and managing those is where the success will be for a longer term resolve of the issues.
We just had Tim Gabbett come to the clinic to do a course, and Tim Gabbett is
yes.
We just had Tim Gabbett come to the clinic before lockdown to do a course, and he talked about the floor and the ceiling. So you've got your ceiling, which is the aim of where you want your patient to be, or your athlete to be in that case, and the floor was where they are. Or where they should be now, but sometimes they're in the basement, so they need to get to the floor before we can even get to the ceiling. So having a progressive overload there. Oh, I think we've just lost Dan.
No, I'm here.
Oh no, you're there. Oh no, we've lost your image.
Yeah, I was just an image, wasn't it? My video wasn't working.
Yeah, your video was there. Yeah, we could see it.
All right.
Yeah. So he was. Oh, there we go. You're back again. Yeah. So he was. He was talking about those incremental steps to get people back to their performance level again, and monitoring their load. Do you with sort of lay people rather than athletes, would you use the internal loading system with them, where you do the exertional minutes times by their RPE? Would you use that with patients?
No, I don't use that particular one, but I can tell you what I do use, and the patient keeps a pain diary. Okay. The response to tendon loading when you're dealing with tendinopathies there's often a delayed response, or let's call it like a pain hangover. So a patient will complete a training session, whether that's resistance training or running or something, and they'll feel okay. Mm-hmm. But it's often the next day that they feel whether they have done too much or whether that was okay for their symptoms. And if they have 2 days of an increase in pain, mm-hmm. then we need to have another look at their loading and see what changes we need to make. Cool. If the symptoms are acceptable and maintained, then that's fine. If the symptoms are reduced, then that means we can up the ante and start to introduce some more loading into the program. So I use that pain diary.
Okay, cool. So we've got some questions here. So one from Chris. Yeah, my battery died. Can you believe it? One from Chris. How do you manage athletes competing at a good level when they have to keep training for major competitions? Does your wording advice change for this type of population? I don't know whether you can hear us, Dan. Can you hear that? Yeah, if you wouldn't mind popping a comment in the comments box just for Chris's question there. So how you find managing athletes competing at a good level when they have to keep training for major competitions? How does your wording or advice change for that population? Yeah, so Paul Gray there as well. I like the poke the bear analogy. So if you've not heard of that before, that's from Greg Lehman. He uses that, so he's a good guy to check out. But you don't want to punch it in the face. Yeah, definitely. Okay, so Dan's come back. Yeah, it's about managing symptoms rather than treatment. Yeah, cool. So it's managing that load so that they can do what they need to do within their training. That's taken a while to come back. Okay, I think what we'll do, Dan, because we're coming up to isometrics help reduce symptoms and passive treatment may help. Yeah, good. So it's often the things that we do in clinic to help reduce the symptoms down can be then the windows we need to get them to do the loading, I think. And they then can buy into what you're trying to do with them and get their training back on track. But it's a combination of everything. We talked about this on the clinical reasoning session earlier today about looking at all aspects of the individual. I think my phone is well and truly gone. Right then, so we did have Dan. I think what we'll do is if you type in your questions, because we've got some homework for you guys to do for the next session that we've got planned, and hopefully we'll get. It's Mark. We were chatting, Dan and I, before this went live, and it was working perfectly. So there we go. But Dan's got some. We honestly were. Dan's got some questions that he's put together for you to keep you busy over the next week. And we're gonna do a tendon talk every Monday at 8 o'clock. Okay, so if you guys want to join us again, hopefully we'll get Dan's sound sorted by then. So he's got some questions that he's going to pop in the chat box for you, and we've also got a Facebook group that we've put together. So if you type in, I'll pop it in the comments as well. So if you type that into Facebook, it will come up with our Facebook group. And there's your question 1. So 3 important points to communicate to your clients. Okay, so that's your first question. And if you pop that on the Facebook page, if you tag Dan or myself in, and then we'll be able to have a look at your responses ready for the next week. This is a really good one. I love finding new stuff. So find one study on tendinopathy from 2019, 2020. Okay, so that'd be a really good one for you guys, especially if you're on the movement therapy diploma as well, and you've just been finding out how to search for things. Katie, surely you can juggle the children and do some literature reviews as well, surely. So find one study on tendinopathy, and then the last one, design one exercise for a lower limb tendon problem and consider compression and load. Okay, so the things that we were talking about today, how the positions that people can get into can cause a compression of the specific tendons. Think about those when you're putting your exercise plans together. Okay, so apologies for the sound problems and my phone then cutting out. We will get it sorted for next Monday. Oh yeah, Dan, the Physio channel on YouTube, brilliant videos on there. Got absolutely tons and tons of really, really good evidence-based tests, exercises, lectures. There's loads of things on there, so definitely check that out. So those are your 3 questions. We're back next Monday, 8 o'clock. Thank you, Dan, if you can hear us. Cheers, mate. Thank you. So again, apologies about the sound, and we'll see you next Monday at 8. Cheers, guys.